Randomized controlled trials and observational studies are not one against the other, are two complementary ways of studying the efficacy of the drug.
In certain instances, the observational studies provide the advantage of being able to conduct or to pursue questions in a timely manner, where a trial would take years before we get the answer.
Randomization is what protects us from selection biases, and it is the only way that guarantees the possibility to establish that the difference that we observe between treatment arms is caused by a treatment.
Hi, my name is Tomas Kalincik. I'm a professor of neurology and a biostatistician at the Clinical Outcomes Research Unit at the University of Melbourne and the Royal Melbourne Hospital Neuroimmunology Centre.
Hello, my name is Maria Pia Sormani. I'm a professor of biostatistics at the University of Genoa in Italy.
And I'm Alan Thompson, editor-in-chief of the MS Journal. You're listening to the ECTRIMS podcast, a new sounding board for the MS research community, and the official podcast of the European Committee for Treatment and Research in Multiple Sclerosis. Today's episode is part of the MS Journal's Controversies in MS series, and we're going to be chatting with Tomas and Maria Pia about using real-world studies to compare disease-modifying treatments in MS. As many of you know, over the recent decades, over a dozen injectable, oral, and monoclonal antibody disease-modifying treatments have been approved for MS based on safety and efficacy results from phase 2 and 3 clinical trials. However, these agents have rarely been compared directly in relation to clinical, MRI and safety variables in clinical trials. In addition, trials are frequently limited by short follow-up and highly selected populations, often lacking any comorbidities. As such, real-world data has become increasingly relevant in MS to compare DMTs in terms of their clinical and MRI effectiveness. This is thanks to large cohorts followed up over long periods of time. And this is the area we would like to explore today. And perhaps I might begin by asking Maria Pia, what do you feel are the strengths and limitations of phase 3 clinical trials in providing comparative data? And perhaps you could give us some examples, good or bad, of previous or underway comparative trials.
Well, Alan, randomized controlled trials are considered to be the gold standard for assessing efficacy of any drug in any field of medicine. And this is because randomization is what protects us from selection biases, and it is the only way that guarantees the possibility to establish that the difference that we observe between treatment arms is caused by a treatment. So this is what in statistical jargon we call establishing a cause-effect relationship. Also, by randomization, we are guaranteed to have an unbiased estimate of the size of the treatment effect. And as you can see, this is a very valuable advantage of randomization, of running a randomized controlled trial. Of course, as you already mentioned, the main criticism to clinical trial is that they are conducted on selected populations. So they are not run on the general real-life cohort of patients that can benefit from the drug. I must say that anyway, this criticism is somehow overestimated. In any book, you will find that clinical trial has a very large internal validity and low external validity. And low external validity means low generalizability. And why I'm saying that it is overestimated, we must take into account that in clinical trials, and especially in MS clinical trials, we always estimate a relative treatment effect. And relative efficacy measures are very surprisingly transportable. Transportability means that you can apply this effect also to other kind of populations. When we say that the treatment reduced relapses by 50%, this means that relapses will pass from 2 to 1 in patients who has 2 relapses per year, and that they pass from 0.5 to 0.25 in people who have a much lower relapse rate. So usually in MS clinical trials, if you examine what happened according to subgroup of patients, usually the treatment effect is very homogeneous. Usually after the conduction of a clinical trial, we have the subgroup analysis estimating whether the treatment is effective in male and females, older and younger people. And usually this comparison, the treatment effect is quite homogeneous. So even if all the people, for example, are not included in the trial, we don't have any reason to expect that the efficacy is reduced in all the people. So this is why I'm saying that sometimes this lack of generalizability is overestimated. The effect of drugs that we estimate in clinical trials can be extrapolated also in people that are not effectively included in the trial.
Okay, thank you for that. Thomas, I don't know whether you'd like to come in or...
Yes, to comment on that point, and the internal and external validities is always the consideration that one bears in mind when deciding between randomized controlled trials and observational studies. And the importance of the assumption, the transferability of the data from randomized controlled trials, the importance underlying concept also the homogeneity of the effect across populations. And it's a very substantial assumption, of course. And particularly in a complex disease such as multiple sclerosis, but also many other neurological diseases where we know or assume that one event leads to another, such as a relapse leads to disability worsening, for example, and all of that probability of disability improvement after relapse is different to a probability of disability improvement after progression that is independent from a relapse. There is a substantial heterogeneity within the population out there in the real world. And what we are learning from some broader trials with the broader inclusion criteria and observational data now is that in certain subpopulations, we now see relative effects when comparing therapies or treatments to placebo that are not necessarily in keeping with the findings of the randomized controlled trials. And that is probably attributable to the heterogeneity or complexity of the underlying disease pathogenesis.
Well, then maybe I could follow up on that. I think it's fair to say you're seen as a champion of comparative observational studies. And I wondered if you could talk a little bit about their advantages over trials, but perhaps also their limitations. What are the issues that are perhaps of some concern? And perhaps also you could give us some examples of the strengths and limitations in some existing comparative studies. So a couple of questions there for you to have a go at.
I start from the easier part. Indisputably, randomized controlled trials are much more robust and much more solid in the generation of the evidence, particularly the causal effect of the intervention on the outcome, simply by the virtue of randomization a priori and prospective acquisition of data. And that is indisputable. Whatever we do with observational design aims to emulate a clinical trial. So we try to come as close to a randomized clinical trial that as we can within the limitation of the data and the methods. Apart from that emphasis on external validity and that substantial flexibility to recruit patients and include in a study of observational data patients as they are treated in clinical practice. And let's face it, us neurologists are a virtuous bunch. We find a way how to treat our patients with the drug that we consider to be the best for the given patient. That allows us the ability to explore the effect of these treatments in scenarios in which they were perhaps not necessarily tested in the pivotal randomized controlled trials. The other advantages are feasibility and high cost effectiveness, particularly in existing data sets on the condition that the data of substantial quality and that there is established homogeneity, or where there is lack of homogeneity, the heterogeneity is understood and accounted for. And in certain instances, the observational studies provide the advantage of being able to conduct or to pursue questions in a timely manner where a trial would take years before we get the answer, we can have an interim answer of substantially high quality to guide treatment decisions before we get the ultimate quality of the statistical inference from randomized controlled trials. And finally, another advantage is the breadth of research questions, where in randomized controlled trials, a trialist typically asks a question about a intervention A versus intervention B, and they ask that question in a certain clinical context and with reference to a certain outcome. In observational data, again, conditional on availability of data, they can go much more broadly with asking the questions. And there are a few good examples of those approaches. The registries from France, the OFSEB registry or the Swedish MS registry have, over the last decade, published a number of excellent examples of studies where they have utilized either registry-based data in case of OFSEB or population-based data in case of the Swedish MS registry with high-quality, highly rigorous methodology. I will not go into the detail, but those examples include examples of appropriate balancing of the compared cohorts and assessment of that balance, and also the assessment of unmeasured bias, which is very important, potential confounder in these studies. Very recently, there was a study published from the French registry, which is a very good example of a question that is really not feasible for an RCT design, and that is a study that looked at the causal association between pregnancy and the disability trajectories, published in Neurology last year. And they found no evidence for causal association between these two phenomena. A very important clinical message that one cannot randomize for.
Thomas, thank you very much for that. I mean, could I just raise the concern sometimes about data quality? And I'm thinking maybe particularly around MRI. Is that something that you think is a real concern?
Absolutely. There are, of course, gaps in the data acquired in clinical practice, and they occur at several levels. It's either unavailability of data. It can be, a good example is safety information. Safety information, almost by definition, is to be collected prospectively and thought about in the context of a protocol, particularly its association with the intervention of interest. The other level is the level of heterogeneity, and there is very substantial heterogeneity that is present across scanners, scanning protocols, and sites that we do not yet have methodological answers to how to homogenize data that come from different sources. The other consideration for the data, absent data, are disability data. Not in all countries, and neurologists would routinely record disability in the form of EDSS. And while in Europe this is a standard practice, for example, in North America, this data can be missing. It's absolutely essential information for appropriate balancing of the compared cohorts.
Great. Thank you for that. I just turned to Maria Pia for a second to see if there's anything you'd like to add. Thomas's fairly comprehensive response.
Yeah. I think that a mistake that we usually do is to compare randomized controlled trial with observational studies as two opposite options. I think that really randomized controlled trial and observational studies has different aims. Observational studies are more from a public health perspective. Randomized controlled trials are more for establishing the pure effect of the drug. If a patient in front of you, and from a randomized controlled trials came up that the drug reduced the relapse rate of 50%, it is quite obvious to the patient that if he does not take the drug, this effect will be diluted or it will disappear. So from a public health perspective, it is very useful to test the efficacy that was detected in a clinical trials on real-life patients, because it takes into account also the compliance to the drug, the toxic effect, and what the cost of the drug, the possibility to take it, the suitability of how the drug is taken by the patient. Randomized controlled trials and observational studies are not one against the other, are two complementary ways of studying the efficacy of the drug. Yeah. Something that I would like to add is that the mistake that has been done in the past is the obsession to rank the efficacy of the drug based on comparative effectiveness assessed in observational studies. What we really need to understand is the long-term balance of the efficacy and safety of the drugs that have been tested in clinical trials on real life. So, we don't want to assess whether one drug is better than the other. This is better done by network meta-analysis that, it's a way to compare treatment efficacy by keeping the randomization. The real question in the long run is, according to this efficacy level, which is the safety of the drug. I think that a lot of incredibly important results have been obtained from observational studies regarding safety. Let's think about PML. Or, different dose scale. We gained a lot of information that is crucial, that is really important, that can be gained on clinical trials, but it is different than comparative effectiveness.
I think your point around complementarity is a really important one. Can I move on to some, from these more general questions, to some very specific questions, which perhaps suggest we might have shorter answers. The first is to Thomas, which is, which observational study design is best suited to deal with drug comparison? And in this regard, perhaps could you mention the potential of pragmatic studies?
Yes, this is unfortunately a very large and complex question, but I'll try to keep it to minimum. Each different question asks for a different design. There are certain approaches that compare treatment effectiveness, and the key there is to balance the compared groups exposed to the compared interventions within the context in which we are comparing, and that context can be predefined as relapse or remitting disease that is being active and so on. And here are a number of techniques. They can be based on direct matching or weighting or propensity score-based methods, or more recently, methods that continue to preserve balance throughout the long-term follow-up, such as methods of causal inference, marginal structural models, and so on, which are, by the way, very useful also for analysis of randomized controlled trials.
Right.
Pragmatic studies is type of a study that is a design term, is a term that is not necessarily directly related to retrospective analysis of data, but it is a certain approach to allocating treatment in clinical practice, and based on the treatment allocation and treatment and decision to allocate treatment, inclusion of patients in a clinical trial. And there are two good examples, very prominent examples nowadays, the TREAT-MS and the DELIVER-MS trials, that are pragmatic trials that look at the timing of high efficacy therapy, where an interesting feature added to these trials is a third arm where patients decide not to be randomized into early or later high efficacy therapy. And these people are entered into an observational arm of the study that is retained in the study. There is much more, of course, to the methodology, but I think these are the key elements.
No, it's really helpful, and it's clearly getting increasingly sophisticated. Maria Pia, can I go to you just to ask which statistical approaches are best suited to reduce the limitations we've talked about in observational comparative studies? How can statistical methods adjust for real-world noise?
The most widely used approach is to adjust for baseline imbalances using propensity score approaches. That is a method in which we adjust the treatment effect estimate by taking into account the differences, the intrinsic difference of the two treatment arms. Of course, this is not, we don't have to apply this adjustment in randomized controlled trials because randomization guarantees that the differences are just by chance, while the differences between two treatment arms in real world, in non-randomized comparison, are not by chance. So this is the true problem of comparative effectiveness. And I've been always a bit critical versus this, not versus the approach itself, but versus the idea that by adjusting by propensity score, we reproduce what a randomized clinical trial is. We must take into account that all these methods of adjustment can adjust just for what we are able to measure, but there are plenty of unmeasurable confounders that we cannot adjust for. So, in my view, the best integration of randomized controlled trials and observational studies is the pragmatic trial. I would love to see more pragmatic trials in the future in MS, especially for example, for more advanced people, for progressive MS, in which we have, many different approaches to test. Also, non-pharmacological intervention that can be easily tested in a pragmatic framework, like diets, exercise, rehabilitation approaches. And these approaches are very well suited for a pragmatic design. And, I think that now we have good registries, good methods of data collection that can support this approach.
Thanks for that. Perhaps I could then go to our final question, and I'm going to ask you both this, but begin with Thomas. Based on what we've discussed so far, and I think this has been a really great discussion, what can we reliably infer from real-world studies? And reliably is the key word here. And what, by contrast, should we be a little more cautious about? Thomas?
I think we have a number of examples in a number of questions that provide us with really reliable knowledge and insights into management of MS. As Maria Pia highlighted, the importance of interpreting treatment effectiveness in the context of safety. While we may not necessarily generate, like in RCTs, the information from the same data set in one go, in one analysis typically, but I've learned to trust the neurologist to synthesize the data, and we now have different sources of data in different studies, where one set of studies looks at the comparative effectiveness of therapies with appropriate methodology and large cohorts in specified clinical context. And another studies, the PASS studies and registries, are now providing more and more information about, importantly, long-term safety of exposure to medication. And there are a good few examples such as TOP and PASS and a few other registries with that information. And very excitingly, we are learning about some other new questions, such as timing of high-efficacy therapy, timing of treatment as such, the purpose of treatment in very early stages of the disease, discontinuation of therapy, and in fact some of other epidemiological, so to speak, features such as pregnancy and its interaction with treatment effectiveness.
Great. Thomas, thank you very much for that. Maria Pia, would you like to answer this question on reliable data and caution?
Yeah, I fully agree with what Thomas was saying. One of the best results from observational studies, in my view, is the stratification of risk we got for PML, that is fully from observational data. So I think that, the balance of safety and efficacy is the most important result that we can have from observational study. What I really don't like to see is the competition between two drugs. I'm not interested to see in observational studies comparing ocrelizumab to ofatumumab to see whether the 0.1 relapse rate of ocrelizumab is superior to the 0.12 relapse rate of ofatumumab. A more comprehensive balance of the efficacy and safety is what we need from observational data.
I take that point very well.
Yes.
Well, thank you, Thomas and Maria Pia, and thanks to everybody for listening. Once again, I'm Alan Thompson, host of the podcast episode and editor-in-chief of the MS Journal. The MS Journal is a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other autoimmune diseases of the central nervous system. You can read much more about this topic and others on the ECTRIMS website, that's ectrims.eu, and please do follow us on Spotify and Apple, and follow ECTRIMS on Twitter, LinkedIn, Facebook, and YouTube.